advisor of the palliative care program at Romila Palliative Care Center, Sneha, which is located in Mumbai, which is a home care palliative care, provides home care services. And she's ex-professor emeritus and head of the pediatrics and neonatology departments at Nair Hospital in Mumbai. And our second speaker for today is Dr. Ruchi Nanavati, who is also from Mumbai. And she's professor emeritus and ex-head of neonatology at KEM Hospital, GS Medical College and KEM Hospital in Mumbai. So now up to you, Dr. Sushma, for the first part of the talk.
Thank you, Veronique, for that introduction, and a warm welcome to everyone who is attending. And I'll just start off my lecture just now. Just a minute.
Perfect. Your slides are seen.
Yeah, you are my slides visible?
Absolutely.
Okay.
Please go ahead.
So I'm going to talk today on what is called as the prenatal or the antenatal palliative care support, which is a part of perinatal palliative care. Our next session by Ruchi will be on neonatal palliative care. It's moving. Yeah. So what are the objectives of my today's talk is just to make you aware of what this is. I'm not sure how many of y'all know about the antenatal palliative care support, but we'll identify together the clinical situations where we can utilize these services. What is the need for in utero infants who are having life-limiting diagnosis, and how to help them out? What are the goals of care, and how to help these families with quality of life care, even in a situation where there is impending, death going to occur. So one of the happiest moments in life of, a family, not just women, but even men, is the period of pregnancy. It's a unique human experience. And the mother feels very joyful, she's excited, and she feels empowered. She feels she's, she's instilled with the strength of, with a sense of strength. She feels, she's carrying the whole world inside her. And she's glowing, she's shining away, she's eagerly the family's wait, expecting a very good outcome. However, in a few families, these dreams are shattered and parental fulfillment is really challenged, where there is detection of severe congenital anomaly. And they feel that the earth has come to, it's a doomsday for them. So how do we support such mothers? And what is the role of this perinatal palliative care? How are we going to help out this tiniest of person who was developing? And there's a very famous saying of a person is a person no matter how small. And this was quoted by Dr. Seuss. The care is different for perinatal palliative care. Care of patients who are carrying, or mothers who are carrying this fetus with a lethal anomaly, is not just a simple routine palliative care, or it's not just the bereavement that's going to occur. These cares have to be pathways which are for the stillborns or the sudden or unexpected losses that are going to occur. We need to understand the psychosocial dynamics of the anticipatory grief, their dreams being extinguished, there's loss of future life events, and there is a sorrow of too soon a loss of a loved one. So when there is a pregnancy with a life-limiting condition, broadly, there are two sets of parents. For majority, the grieving process starts even before the family can meet the newborn or the fetus. For some, however, which is a smaller percentage, but in India also this percentage is rising, the family seeks an opportunity to celebrate and honor life of their child, and they try and plan the ongoing pregnancy and they make a birth plan. Sorry that the slides are giving a little problem. So what is happening? Why is there an importance and the growing need that is occurring? There are rapid advances in the ability to diagnose fetal anomalies. We all know now there are high resolution ultrasounds, prenatal serum screening is there, there are non-invasive genetic tests, which you can do in the first trimester itself without using even the invasive procedures like CVS and amniocentesis, which have also taken a stride, in being far more refined and giving better results. So the detection is becoming more and it's coming much earlier. Though the overall incidence per se of the congenital defects has really remained almost the same. Worldwide, the burden of major congenital anomalies is more than 8 million babies worldwide are born with a serious birth defect every year. And they account for nearly 7% of neonatal mortality, and about 3.3 million children die under 5 years every year. But not to be surprised, 94% of these severe congenital anomalies occur in the low and the middle income countries. That's because of lack of nutritious foods, infections, lack of proper health care, unawareness, and screening tests, which are lacking. Indian statistics, as usual, we are always at a loss. We still have to establish the national surveillance, though we have the RBSK, and there is paucity of Indian studies. There was a study in 2016, as well as the State of Newborn Health in India, published in 2016, quoted that congenital anomalies account for nearly 8% of neonatal deaths, which is nearly double or maybe 5 times that of middle income countries and high income countries. And as per BDA, the prevalence of major congenital anomalies is about 230 per 10,000 births, and congenital heart diseases were almost double that of neural tube defects. So where does India stand firstly for palliative care? Palliative care is gaining recognition in contemporary adult health care, but there's hardly any penetration in the NICU setup. So for adult palliative care, I can say we are still in infancy. For pediatric palliative care, we are still a neonate. Whereas for perinatal palliative care, we are still sitting in the womb, and we need to bring about this awareness. By definition, perinatal palliative care is a coordinated care strategy that focuses on maximizing the quality of life. It tries to manage the distressing symptoms that the mother is going through or the family, and provision of care occurs right from diagnosis through death and bereavement. The goal of this is to provide support and continuity of care throughout the pregnancy, delivery, postpartum period, and neonatal period. In short, it consists both of the antenatal and the neonatal palliative care. So the prenatal or the antenatal palliative care support is a relatively innovative and a far more compassionate model. It has increased over the years, but still there aren't any standardized protocols except for a few countries. They provide support for parents And as we see that more and more parents and families, they're finding themselves in these heartbreaking situations as prenatal testing continues to advance. There are more than 20% of mothers, in fact, figures from abroad mention almost 70% of mothers who desire to carry their pregnancy to term no matter what the diagnosis is. So, as I said, that perinatal palliative care is a continuum of care encompassing both the prenatal and the neonatal concept. It starts with the high risk pregnancy with the birth anomaly. In addition to giving general obstetric care, and there is the maternal, fetal, perinatal palliative care teams. And then there is birth and later bereavement and support. So, what are the components of perinatal palliative care? A formal prenatal consultation, development of the birth plan, access to other neonatal and pediatric specialties, and many more, and give them the support and care and continue the services. So, what's the traditional thinking that usually when this is diagnosed or a mother has a pregnancy with a life limiting condition, a fetus having a life limiting condition? The previous counseling used to be just terminate the pregnancy. It was well intentioned, and the obstetricians and the team would feel, let's just get over with. Again, it was well intentioned that maybe it will avoid, the medical problems or the complications of pregnancy if mother is carrying such a child. There was a fear of increased maternal mortality also. And the physician somewhere or the obstetrician felt that they need to do something and deal with this discomfort of the bereaved parents. And that's how our traditional thinking was. Excuse me. But we need to think, do women grieve after terminating pregnancies? Yes, very much. And it is as intense as if the mother was to deliver this baby and was going to either there was a spontaneous perinatal loss or a loss in a few days. And this was studied by Zene et al. And she found 23 mothers who underwent MTP, 4 had major depression, and they sought psychiatric counseling. So when there is a diagnosis of fetal anomaly and subsequent termination, that is also associated with a lot of psychological morbidity. So which is the cohort which will be eligible for this type of prenatal continued with postnatal care? There are, of course, the major group is those belonging to at the period of viability, anywhere after 22 weeks or near that. And then there are the confirmed life-limiting conditions or potentially life-limiting. And in the life-limiting conditions, we definitely know that there is a very high chance that death could occur either in utero or in early infancy. And it's an unequivocal diagnosis. Whereas in the potentially life-limiting conditions like severe hydrocephalus, your Potters, your hydrops, there is a significant chance of death in utero, maybe in the newborn period and infancy, but the prognosis may not be very clear till birth or even after that. And when do we initiate this prenatal palliative care? Initiate palliative care at any point from viability. I know the weeks have been reducing from 24 to 23 and now to 22 weeks. And sometimes parents, if through genetic test, have come to know even earlier, maybe they're carrying a trisomy 13, they wish to understand this care planning even earlier. And of course, the aim is to give them high quality ongoing care. And who's the team who's going to be involved? It's best if there is a care coordinator. Why? Because there are so many people involved. There is the obstetric teams, there could be the genetic team, there could be the ancillary professionals, the medical professionals, the neonatal team, and there could be the family per se along with them.
I think that we just give a little bit of time.
Yeah, Dr. Veronica, I think, did we lose Dr. Shishma?
Dr. Sushma may have had an internet issue.
Yeah, because she's not here.
She's going to join again.
Yeah, yeah.
I thought I was the one who was frozen, actually. But
Dr. Ruchi ma'am, like, can you just start something so that the crowd doesn't wait once Dr. Shishma
Or you
joins
want me
back?
to start a one?
I could continue her presentation if you want. And
Yeah, okay, fine.
just
Yeah, maybe just you can start something,
just a second.
or if they have any questions.
Let me. Yes, up to now, of course, if anyone has a question, just check if Dr. Ruchi is joining.
Yeah, I have joined already. I'm here.
Sorry, Doctor.
No, no.
No, I
Yeah,
don't think we want to jump to neonatal.
Dr.
I was
Shishma,
thinking-
Dr. Shishma is joining back. She's joining back.
Joining back. Okay, it's
Yeah.
just a matter of 2 minutes. So as you understand, there are issues related to level viability of the babies and
Please,
Dr.
please
Sushma.
make me the host to share the link.
Welcome back.
Yes, I have
Okay.
done.
Well, was it this slide or should I go one slide higher? Was it here? The team? I don't even know when I got disconnected. Did I finish this?
Yes, you did now.
Yes, yes.
Okay, so then did I tell you all about the initiation? Yes?
Yes.
I can't hear you. I don't know what these lines are coming.
Yes.
I think you are drawing something, so I think your whiteboard is on.
Slide number 20.
Slide number 21 minute. What is this? Why is there a diagram coming? Should I how do I remove these lines? Is it going to keep coming?
Yes, just a
Okay,
second.
can I reconnect? Can I share again maybe?
I think, yeah, that's best
Yeah,
thing.
just what do I do? Stop share or what?
I will stop share. You can start all over again.
Okay, please stop share and let me. So sorry for all this confusion. Okay, I'll share again.
That's the one.
Okay. Is that okay? Can we see it?
Yes, it is visible. Your slide
It is
is
visible. Okay, just a minute. Let me just see, why did the Wi-Fi also? Okay, anyhow, I can always see. So with so many teams members, it's always good to have a care coordinator. And we set the stage for a family meeting. Ask the family who would they like to be present for a multidisciplinary meeting, whether it's their friends, their family members, some elders and some, priest or clergy. Find a private place, start introducing all those who are in the room at the table and sit across for good eye-to-eye contact. involve the infant's primary nurse if possible, and the team involvement may include even the NICU team or the hospice team. Just a minute. And as we progress for the family meeting, we assess the family's understanding of the fetus, of the condition, what is the goal of our meeting, and we can ask the mother or the family what is their preferred terminology for the fetus, the baby, the pregnancy, or have they named the baby already? And once again, the palliative care physician reviews the infant's main clinical diagnosis and what are the comorbidities likely to occur. There could be differences in opinion between family members. We need to explain that to the family. And what are the tenets of the prenatal palliative care? An informed consent, and we need to follow all the ethical principles. Give information effectively with a shared decision with the team, and we walk the path with these parents and never abandon them. And later there is bereavement support and hospital-based, whether they want the care or the community-based program. Informed consent and how we are making sure that all ethical considerations are taking place, and that is autonomy. The women should be having the control for all the decisions on the options that we give. It should be an informed consent and sign should be taken. It should be a beneficent care and do everything that will be beneficiary. And the ethics of complex shared decision making so that we respect the autonomy. Counseling parents should be in a careful and sensitive manner. I'm not going to repeat too many principles of counseling as we've had a wonderful session with Dr. Gayatri. We break the information in small chunks and focus on the key messages. We listen to them very empathetically. We listen carefully, not just hear. We must listen also and reflect back, encourage that. Allow the silence. The mother may become very emotional or the family is emotional. And demonstrate the willingness to consider parents' interests. That's the best way to win over the families, and they will also walk along with you. And be culturally sensitive. The information shared should be truthful and scientific with total transparency. We can tell them of prognosis and we discuss all the care options. We of course tell them that the ultimate prognosis will be given only after birth, or it can change also. And we explain to them that how there could be a diagnostic uncertainty too. And the spectrum of care that we can offer to such mothers, whether it's just termination, induction of an earlier labor, or they may go in for a full resuscitation and treatment. Remember that the main stakeholder is the family, or they may carry on to term and they are willing for this perinatal palliative care. Though all are valid options, but we go by the family. And we give time to the family to accommodate, to re-goal. And there is what is called as the satisficing cycle. Once their dreams have been shattered and now they have to look at the realities, they try to find out, they try to negotiate, whether it's the negotiation with you or with God. And they take a long time and we need to support them through this to reset their priorities and goals. And it's, remember again, a shared decision making. We help them out definitely, but primarily let us take into consideration even what the patient is thinking, and together then we make a decision. So what are the goals of these parents? And what is famously called as, let the parents parent the child. And that's what we find now. Sorry. what are their, goals? To be treated with honesty, to recognize that this smallest human is a real human being, to have that dignity, to express emotions, to have that communication, and still have those hopes and goals. And that's how we're going to allow them to parent this baby. What are the care plans that we can together map? And before we map on the care plan principles, again, a review of the fetal diagnosis should be done. And we establish a therapeutic alliance. And the aim should be within reasonable, the goals and the aim and the plan should be within reasonable expectations. And here are the family goals. Here are our team goals. These they make because they feel responsible. They feel that they have to do everything for that little human being. And we use our skills and knowledge. And together we will make this birth plan. Yes?
Krishna ma'am, I think there is a lag in between. So is it the same for everyone or?
No, it is okay.
Okay.
The slides are.
Please go ahead. Yeah, please go.
So is the slides and the, is the talk coming at the same time?
Yes, birth plan. That's okay.
Here, we need to clarify the maternal goals and clarify the neonatal goals. Where will the delivery be? Will the parents allow the fetal monitoring? What is the mode of delivery? Who will be in attendance at that time? Will there be anybody? The best situation would be if anybody from the perinatal team is also there. What medications can we use? Clarify even the neonatal goals. Have they agreed for resuscitation? And will they go ahead with skin-to-skin care, with bonding, with feeding, and special events or memory making and spiritual care, which would be covered in the next talk. And who will be mentoring in the delivery room? Who are the primary caregivers? And are they going to keep only in the delivery room? Would they want a special room? Have they agreed for the NICU but in a side room? Is the focus only on bonding and comfort? And we need to achieve this state of comfort of temperature, hunger, thirst, and the basic aim being alleviation of discomfort and pain. And parents who want to have a constructive memory, which, as I said, would be covered in the next talk. What are the ways still to empower the mothers and families and to reduce their grief? They can spend a lot of quality time. You need to empower these families. They want some memory making, and that helps to really reduce their grief. You can explain about organ donation. You can even explain to them what is the necessity of doing an autopsy. And such parents become good parent support groups and they become champions of palliative care. Let us give a chance and walk with them to reduce their grief. Now, what are the challenges of perinatal palliative care? Although we know that it is a growing field, it's a new field, yet the coverage nationwide is very low. And what are the contributing factors to this low perinatal palliative care? Lack of awareness. I think the first and foremost is amongst we physicians. We don't have the necessary education, training. The lack of awareness in parents and community, non-availability of such programs, lack of standardized protocols, patient access issues, as we find that these services are available only to few hospitals and mainly in cities. And I can count on my fingers that we have only very few cities and places where this is being introduced. For example, in Mumbai, It is at Wadia Hospital, where Veronic heads. It is at KEM, where Anita and Ruchi head. It is in Bangalore. It is there with Gayatri in Hyderabad. And we are waiting to increase. I'm sure there are some more centers of which I'm not aware. So lack of all these protocols, though we do have this of the allied health professionals, we try and go by it. Even though there are so many hurdles, there are far more benefits. And implementing prenatal palliative care ensures that a specific care is provided to newborns with this suspected life-limiting condition. It helps in redirection of care and palliative medication. There is a decrease in variability of use of the end-of-life interventions. Parents feel that their children were treated respectfully. They were treated respectfully. There was a caring and a peaceful and non-invasive environment, and an overall state of comfort could be achieved. So, though we cannot change really the outcome of these babies, we need to continue and help them out during this journey of us. There is a beautiful book called as The Gift of Time, written by Amy Kubelbach, who has written this book for pregnant women who are expecting a baby with a life-limiting condition. It's a gentle and a practical guide. As more and more mothers or parents are opting for this, it's a good book to gift them. They can go step by step through the challenges and the emotional experience. Let us all together vow together that we would help all such mothers who are willing to take this journey. Thank you very much for a patient hearing. And before I end, I thought it would be appropriate if Veronique could share a small case from her unit. Thank you, Veronique, for agreeing for this. And I'll introduce you as the consultant and head of Palliative and Supportive Care Unit at Wadia Children's Hospital in Nauroji, Wadia.
Thank you very much, Sushma. You will keep
I move the slides for you, Veronique? Okay.
Yes, please. This is a case which we have looked after a few weeks ago, of a 25-year-old gravida, second pregnancy. She had lost the first baby, but it was a miscarriage at 2 months of pregnancy. And they were that was a product of a third-degree consanguineous marriage. So we were called by the NICU consultant because the obstetricians informed of this case. So the anomaly scan at 20 weeks had shown bilateral kidney agenesis, renal agenesis. And parents didn't want to opt for MTP, which was offered to them, but they wanted to provide comfort care to their baby. And they said they had faith in Allah. They were asking for a miracle. And so we were called when the mother had been admitted for already 39 weeks and waiting for spontaneous delivery. So we elicited with them, no, please stay on the line. Yes, we elicited their wishes. They wanted that no active resuscitation be attempted at birth. They wanted to spend the maximum time with the baby after birth and to make sure that the baby could be seen, taken in the arms by the father, by the two grandmothers, and then they had rituals which they wanted to do before the baby's expected death would occur. They didn't want any hand and footprints or pictures with the baby. We showed them what we often offer, and many families do want to have this memory making. But we then took very detailed documentation of their wishes in the file, which is always, we make a two-sided table we wish, we want this, and we do not want. We find it very powerful to start with a positive aspect. We want comfort care. We want to have time with the baby and so on. And then we do not want resuscitation. We do not want needle pricks. We do not want NICU shifting if possible. So we needed to coordinate the care plan with the gynae obstetrician because they didn't want to keep the baby for more than 2 hours in the labor room. By that time, we have already changed those rules because they have seen how powerful it is. And so there's no need to transfer the baby to the NICU. And then we provided daily emotional support to the mother and to the grandmothers and to the father for 8 days, waiting for the delivery to happen. But spontaneous delivery actually did not start. And the mother already had religious books. We encouraged her to read that. And it was very stressful for her to see in that antenatal ward. Then mothers also walk in and out with their babies having delivered. So we gave her a stress ball, making sure that it didn't have smiley, because usually our stress balls have a smiley. And a word search book. She knew English, and that is very addictive, and that kept her busy. Sushma, the next slide, please. Then finally, the obstetricians could not induce labor because there was placenta previa, and LSCS was done. A baby girl live was born. We always tell them that the baby may also be stillbirth. She did not cry immediately after birth, and she was dysmorphic with retrognathia. She had also finger dysmorphism, low set ears, and there was poor respiratory movements. So we immediately went into the OT area, making sure that we could take the baby. Next slide. Take the baby to the mother's side. We immediately did skin to skin contact, making her touch the skin, and she had tears in her eyes. They were still stitching her LSCS. Then we took the baby to the father, and when shifting to the labor ward, we insisted that our palliative care nurse would carry the baby. We didn't want the baby to be on a trolley because it was very precious time. The baby needed to have that comfort. So initially to the operation theater entrance for the father and the relatives, then taken to the labor ward. One of our team went beforehand to make sure we would have privacy and permission for the father to enter and to stay at the mother's bedside. And then the mom calmed down. The father was adamant. You can see on this picture, the baby has been placed on the side of the mother on the bed. You can see our nurse and our psychologist, 2 psychologists. The one in yellow is a senior psychologist. And then the father was adamant that the mother should look at the baby. And slowly she started touching the baby. She calmed down and she developed an attachment to the baby, which helps a lot in the further bereavement. The baby was declared dead in the labor ward at 2 hours of life, and all the wishes of the family were fulfilled. There may be another slide. I'm not sure.
Yeah.
Then we continued bereavement care for the 4 days that till the discharge of the mother in the postpartum ward. And when the mother was discharged from so we have a twin hospital, children's hospital and maternity hospital. He called, looked for us, and came to thank us. And we continue to provide bereavement care on the phone. That's just
thank you. Yes, thank you,
Thanks.
Veronique, for this. I'll just 1 minute stop sharing.
So we will now invite Dr. Ruchi Nanavati to continue in the neonatal period with neonatal palliative care.
Good afternoon. Is the screen visible?
Yes.
Yes, it is.
Yeah. Good afternoon, my colleagues and friends. At the outset, I thank Indian Academy of Pediatrics Pain and Palliative Care chapter for organizing this wonderful program and to take this initiative, and for inviting me to share my thoughts about neonatal palliative care. Now, we have just heard about perinatal care, and let me start with a case. This was a 27-weeker with a birth weight of 850 grams, born to a mother with severe preeclampsia. The parents didn't give consent for LSCS. The baby did not cry after birth, was on positive pressure ventilation till NICU admission, had severe HI, required mechanical ventilation, and there was no spontaneous respiration till 96 hours. On day 3, the cranial USG showed cerebellar hemorrhage with gross hydrocephalus. Parental counseling was done, and on day 4-5, the father actually approached us and asked us, requested us not to escalate the medical care. So what we can do with this baby? What do you have in your hand is the continuum of care. And there are no curative options inside. So you just continue the care. But when we look at, what type of care these babies require, what they require is a neonatal palliative care, what we are going to look at today. So we have seen one type of scenario, and all of us, have seen these cases, and we have discussed one such case. The another scenario is a baby born to a 20-year-old mother, transferred from a peripheral center for meningomyelocele. The baby also had Arnold-Chiari malformation, had hydrocephalus, paraplegia. The surgery was not advised, and the baby was more than 4 weeks old. And at that particular time, we had 3 other neonates in NICU who were born with holoprosencephaly. So what type of care we, sort of offer these babies? And the third scenario is the babies who are born with, a mother having some complication, leaking PV. This baby had RDS, required ventilation, developed ventilated associated pneumonia, bronchopulmonary dysplasia, necrotizing enterocolitis, was operated. And this particular child was at the age of 47 days, was still not on oral feeds. And this is nothing new. All of us have seen this case. And what code tells us that you cure sometimes, treat often, but provide comfort always. And what comfort care we give to these babies is neonatal palliative care. And in spite of that, there are no guidelines by the in government, or there are no guidelines by the national pediatric or neonatology bodies. And we are in the process of formatting this, but this is the current state that we don't have official guidelines. So when we look at neonatal palliative care, we require to answer basic questions: that what is neonatal palliative care? Which babies need palliative care? When to initiate? Who are the team members? Where to deliver? How to deliver? What is end of life care? And what is post end of life care? So as the Carlton and curator has said, that the neonatal palliative care is a holistic care. It's a comprehensive approach for a baby who is not going to get better. So in short, that this is a care to prevent the this thing, and to relieve the baby's suffering. So what care you give is a neonatal palliative care. So when you look at palliative care, it actually embraces the physical, social, and spiritual element, provides that care, focuses on the enhancement of quality of life. Whatever the quality of life the baby has, the quantity of life the baby has, you are looking at enhancement of the quality, supports the family, and actually helps the family through the baby's death, and also following the death, that is bereavement. So this is what we look at when we talk about palliative care. So looking at our care, what it tells us, that what we are supposed to do, that first, do no harm to the babies. That is a primary intention of whatever care we provide to the babies. And to this, your first step in neonatal palliative care is to have your policy. And you can see that this particular hospital in UK Way back in 2014, almost about 10 years back, they had the policy for the neonatal palliative care in place. While now, in our unit, from 2021, we have the policy laid down for neonatal palliative care. So we know what are our indications, what palliative care we are giving. And this is the first step in providing the palliative care. So the question is, the first question, that which babies need palliative care? And when we look at this, you have 5 broad categories. And the first category is that the babies who have antenatal or postnatal diagnosis of a condition which is not compatible with long-term survival. Having bilateral, baby having bilateral renal agenesis, anencephaly. And I remember a child, many years back, we had a baby born with anencephaly. We, of course, kept the baby in labor ward, and actually we were waiting for the baby to die. The baby didn't die, and after a few hours, we decided to transfer this baby to NICU, and this baby actually lived for 5 to 7 days. It was very difficult for the mother, it was difficult for the other patients, the other mothers, and also for, as a healthcare workers, that when this baby is surviving, you are waiting for the baby to die, this baby is surviving, and what do we do? So this is one group of category. The second one is that you have an antenatal or postnatal diagnosis of a condition where there is a high risk of significant morbidity, like bilateral, severe hydronephrosis with severely impaired renal function, severe spina bifida. This is the second category. The third category is that the babies are born at the margins of viability, about which Sushma spoke. So, of course, the margins of viability differ as per the different countries. We don't have the guidelines for that, but also changes from institution to institution and from, state-wise, and from, of course, from country to country. So that is the third category. The fourth category is that where there is a likelihood of severe impairment of quality of life. Like the baby which we discussed, like severe baby having severe HI. If this baby survives, there is going to be severe impairment of the quality of life. And the last category is when there is unbearable suffering, that the baby is with, so where sometimes the palliative care is in better interest of the baby than providing the NICU care, like babies with necrotizing enterocolitis, severe HI. These babies have unbearable suffering, and one requires to take decision, of course, with the parents, whether palliative care is required. There is also pre-birth planning care, which we have just heard. So when we look at neonatal palliative care, there are basically 2 trajectories. One, that there is acute deterioration leading to death, like the baby is born with severe and lethal congenital anomalies, and more gradual decline in the health status, with intermittent phases of improvement, worsening, but ultimately leading to death. And that is borderline of viability, grade 4 IVH, HI, and severe NEC. So these are the 2 trajectories what we see in the neonatal age group. So the first crucial step, what we have seen, is the early identification. And here the baby which we discussed initially belonged to category A, where there was, expected severe impairment of quality of life. And this assessment requires to be done by the senior clinician and not by the junior. Of course, you require a senior person to take this decision. Here, parents are approached us to not to escalate the care, because this particular father believed that the preterm baby, if survives, will be neurologically abnormal. The long-term outcome is going to be abnormal, and that's why he requested not to increase or, provide any additional care to the child. Now, when we look at what happens with early initiation of palliative care, so way back, in January 1994, the studies have shown that there are fewer, painful procedure, tube insertions, blood, sending for investigation, and less use of all life-saving agents. Also, there is few cardiopulmonary resuscitation is required. And more important is that there is an impact on the bereavement process, and it helps the parents and the family to have psychological and emotional adjustment. So palliative care, when initiated early, actually helps the family and also the healthcare workers. So who, when, where, and how to initiate palliative care? Now, the second step is formation of a palliative care. So for this baby, our team consisted of neonatologists, resident doctors, nurses, and radiologists because the baby had IVH. Now, is the question is that team same every time? Of course, not. The basic members are same. The core team is same, but other members are as per the clinical case, like social workers most of the times involved, pain and palliative care consultant, which is, the available in the Western world. As per the case, you require pediatric surgeons, cardiologists, neurosurgeons. So the team will change as per, whatever the case is. And finally, it is the outcome, of the entire team working together, keeping the baby in mind. So when the palliative care discussion takes place, you have to think of the possible outcome and prognosis, which may be death or a severe neurodevelopmental impairment like cerebral palsy, neurocognitive disability. You have to have consensus amongst the team members. And you have to know that it's not the just question of days. Baby might live for days, weeks, with high likelihood of death, and there has to be consensus within the team. Now, when our team planned palliative care, it was a predetermined date and time. You can't go and say, call the parents, on a particular day when you are on the rounds. You have to give them the date and time. You have to have face-to-face discussion. Better that both the parents are present. You do it in a faculty room or a counseling if you have, preferably from a, in a quiet place which is away from NICU, and give adequate time, which is the problem with most of us. You let the parents understand fully what is the baby's condition, what is the management, what is the prognosis, as well as allow them to ask questions if they have, any anxiety or the fear the patients have. Let them ask the questions. Here, the discussion was initiated by us, by the senior members. We use the pictorial demonstration you can use now. Suppose when we are talking of IVH, you can show them a picture of USG and say that all this white you can see is actually the blood in the baby's brain. So they can understand. For this particular case, we required 3 sessions before the parents took a final decision. In spite of they have, actually had approached us, the parents were urged to ask questions, and this father asked, can this blade be removed? So once the parents fully understand the clinical status, and and then the discussion goes on palliative care and the various aspects of palliative care. And again, very important, which as a medical people, we are not very serious about this, is the documentation. So you document what you have discussed, and also take the signature of the parents and the witness, and you as a faculty and other members, please sign it. So what we did, that time we were not having a separate neonatal palliative care room, which we right now have. So we told them the period of palliative care might be for a few days. The place we selected a corner of NICU where, the chair was given to the mother. The baby was on ventilator. We told them about pain relief, comfort care, and also spoke about supportive management. And this was the baby which you can see in the picture here. We also communicated and documented, gave the parent choice that how do they want to spend time with the baby. And we also decided advanced care plan regarding resuscitation guidelines, what to do in the event of acute deterioration. So everyone knows, the team members know, and also the family knows that suddenly there is a deterioration, what to be done. And we decided on not to escalate the care as far as the ventilation is concerned. Now on day 5, this baby's spontaneous respiration came back, but they were very shallow. And frequency increased, but since the baby was on ventilator, we could see tidal volume and it was very less. The day 6 baby had feed intolerance. We continued trials tube feeding with express breast milk. The mother or PDHM, whatever is available. We continued ventilation because we still don't have legal guidelines. On day 15, the baby had anemia. Hemoglobin was 6. The baby was not transfused. We continued the comfort care and gave feedback to the parents religiously, almost daily or alternate day. The physical comfort care, actually, you continue to give care to minimize the distress. So you position the baby properly, whatever is most comfortable for the child. Provide skin care, provide mouth care, give human contact, including breastfeeding, and if indicated, or if feasible more than that, skin-to-skin contact or a kangaroo mother care. Don't forget the developmental needs of this particular child. So when we talk about nutrition, the another most important aspect of neonatal care is nutrition. So when we are looking at nutrition during palliative care, your whole aim is to provide comfort, that the uncomfort or the distress what the baby can get because of hunger pains, that you don't want. Your aim is not to look at the growth of the child because you are giving palliative care. So decide that, let that be in your mind. Route of feeding is whatever is suitable. It can be breastfeeding, it can be RT feeding, it can be Vati spoon feeding, and breastfeeding, if possible, may be more comfortable for the baby and mother. So that can be definitely done. The another neglected aspect, not only in the palliative care, but your routine NICU management, is the pain assessment and pain relief. So we provided a dedicated area, the environment with minimal, sound and light disturbances. Pain assessment was done regularly with a pain scale, which we use in our unit is PIPP revised. That is premature infant pain profile, revised one. And the regular monitoring of the pain state was done to do the necessary modifications. Now, when we look at pain relief, you have non-pharmacological interventions, you have pharmacological interventions. And the non-pharmacological interventions are kangaroo mother care, breastfeeding, nesting or providing boundaries or contentment for the child, non-nutritive sucking, and family-centered care. Involvement of the family in the care of the baby who is not going to get better. Pharmacological interventions, you provide, the analgesia for acute procedural pain, post-operative sometimes, paracetamol, 24% sucrose, which some people consider as a non-pharmacological intervention, chronic pain, long-term sedation. But the parent should be aware of the side effects of the, medication. This is, more again in the Western world. Here during routine care also, we sometimes do not inform them about the side effects, but you are supposed to be ideally informing them about the side effects of whatever medication you are giving. In addition to that, the take care of the other symptoms like vomiting, constipation, diarrhea, reflux if the baby has, airway secretions, hypersalivation, and seizures. So you should have guidelines for this particular thing, so that there is no, that the team members are aware that how these things should be managed. As far as the ventilations are it's concerned, the babies with worsening respiratory distress, they can be kept under oxygen hood if you have already taken a decision to actually withhold the ventilation before the ventilation is initiated. But once the ventilatory care is initiated, since we don't have the legal guidelines, we continued the ventilatory care for this baby. This is a gap yet to be bridged in our country. And as I said, we continued the ventilation. We didn't escalate the ventilatory care. What is another aspect of palliative care is a psychological and emotional support. So the parents and family, to enable them to come in terms with the situation, as well as to empower them to take decisions. The healthcare workers also need, the emotional support, because they are seeing these babies, and it actually, whatever you do in NICU, whatever you see, you do take it home, and it disturbs you. So they also require emotional care, especially the nurses. And here the senior faculty and 2 residents followed this particular case. They were sort of in charge of this particular case, including the counseling for the parents, and that, the psychological support was taken care of. You also need to have the religious support, but have the guidelines. You respect the religious sentiments of the family, and you can't say, no, we will not, avoid anything, avoid to support any of this particular thing. But you have to have a policy. You decide whether you want to do any particular religious support activity bedside, or you have a separate area. So there are NICUs where, there is a separate room which is called as a prayer room. So the baby is not only palliative care, but sometimes the babies who are admitted in NICU, the parents want to spend some time, worshipping, doing prayers. So there is a place. In our department, we don't have a separate room, but we have a corner where, the parents can be, they are sort of advised to whatever this thing they want to do a prayer, that can be done at that particular area. So now, as far as this baby was concerned, the parents were allowed in NICU. Otherwise, also the parents are allowed in our NICU. They spent time with the baby and they took the photographs of the child, and the parents were regularly counseled. The baby actually passed away on day 21 of life. And the parents, when we look at parents' feelings, they accepted the death. The father said just one sentence that her sufferings are over. And it had a positive impact on the emotional adjustment of this family. They came for follow-up subsequently. And here, when you are doing this, you can offer them the choices for creating memories and guidelines for any, particular photographs if they want to take. Now, what we observe in, in our this, that there are parents who don't want any memories. They don't want photograph. They don't want anything. So you respect whatever they say, but if they want something, you can definitely guide it. So after all this, the time comes, which is the end of life. And when we are talking of end of life care, the Institute of Medicine says that a decent or a good death is something which is free from avoidable stress, suffering, not only for the baby, but for the family and caregivers. And it is in accordance with the patient's family wishes and reasonably, consistent with clinical this thing and the ethical standard. So this is what is, the Institute of Medicine says about end of life care. So when we look at various components of end of life care, you have to predict the time of death. You have to tell the parents, because you can tell them that the baby is worsening. It might be a day or two, or it might be the same day. Tell them the location of care and death, that where the baby will be in the same place or is going to be shifted to the another room or whatever. Again, tell them about resuscitation plans. Prepare them. The death preparedness is important. You require to tell them that when the baby becomes serious and is about to die, there might be, that the baby's, of course, the baby's activity will go down. The baby's color might change. The baby might look pale. The baby might look blue. This thing, there will be changes in the monitor, because, as the mother stay in NICU for a long time, they actually come and tell you that, the saturation is in the normal, that today the saturation was 86 and something. So they understand. So you tell them that, this thing, the saturation will go down, the numbers will be raised, the heart rate will come down. So prepare them for the death. And this is very important and mandatory. If required, you prepare them for post-mortem examination. A first child having syndromic thing, for the second pregnancy, they are better placed if you are able to diagnose what the baby has. And tissue donation. But of course, as far as India is concerned, the neonatal tissue donation program is not there till now. But when we look at the Western world, the organ donation, you can donate the heart valves, hepatocytes, and cornea. Ensure the parents that they are given a choice if the baby is eligible, and the donation can be seen as a positive event following the baby's death, which is a tragic event. And this should be offered if it is appropriate and the baby meets with criteria for donation. So the tissue donation does happen in the Western world, and it can be practiced. The another thing which is, in the Western world, but not here, that the babies are not taken home, from a palliative care. They can be taken home, but there is an option to take them, something like a hospice care, where the not home, not hospital, like here we have it for, cancer patients, for adult patients, but you don't have such facilities still for newborn babies, so which is available in the Western world. So this is one of the options where the babies, if they are not comfortable taking this baby home, there are such facilities available in the Western world. Now, after the death of the child, you are supposed to help them for certification, registration of death, communicate, and do the follow-up. So depending on what the baby has, the follow-up is very, very important. And this, when we look at all this, the end of life decision making in newborns with adverse prognosis is an ethical challenge. And the ethical issues are always controversial. And so is, the end of life care in newborns. And as what case showed you is one of our first cases. And we analyzed this case and we learned We applied it in the next case, and the story continues even till today. We do periodic audits to identify the gaps and to improve the quality of palliative care. And that's the basic, the objective of audit, which all of us know. So you're required to do that and, carry on with the palliative care. So if we look at, the neonatal palliative care, what is the current status in India? It's almost like, this baby saying that don't tell us what is the current status in India. And here, why it is so, because Indian health issues are diverse. They are voluminous and far different from any country in the world. And that's why we are still struggling with, your ACA babies, prematurity, sepsis, asphyxia, so many things. So the neonatal palliative care policies are still to emerge. So when we did a study which was published in 2022, we looked at neonatal palliative care in an Indian perspective. And what we found that the palliative care structured policy was present or was evident only in 10% of NICUs in India, and there were a lot of barriers for neonatal palliative care. And what we identified is that lack of knowledge was almost in 17% of the healthcare workers were not aware that there is something like palliative care. Everyone said we don't have time, there is no time for the routine care, where do we give palliative care? 16%. Inadequate space. We know in a public hospital, the bed is shared by, that there are 2 babies, 3 babies in one bed. How can you give a separate bed for a palliative care? So inadequate space is a real problem. Inadequate human resource. You have, one sister managing 5 babies, 6 babies, at times more. And where is, you have a separate nurse for managing baby under palliative care. So inadequate human resource. Parental resistance, it's very difficult for them to understand and to, actually understand and give permission for palliative care. So there is a resistance for that. The healthcare workers resistance, because they say, what is the need? So that was in 25%. One of the highest this thing, that healthcare workers were resistant to give, palliative care, maybe because of lack of knowledge and other factors. But finally, this was for almost in 25% of the cases. And there was always a fear of medical legal litigation, that there are no guidelines and I do palliative care for this baby. Where do I stand as far as the medical legal issues are concerned? So these are the different, the barriers which we found. And when we look at the, what are the other studies which are done in the world, what we found that the barriers in referring neonatal patients to the perinatal palliative care, a French multicentric study showed the similar things. Almost the barriers were same. And same is the study which was done in the perinatal palliative care by nurses in Poland. And they all found that, same thing, the healthcare resistance and parental resistance and everything, and the lack of knowledge being the main barriers as far as the palliative care is concerned. So when we plan, moving towards palliative care in India, what we require is first is the recognition for the need for neonatal palliative care among healthcare workers. And, the IAP has taken initiative, and, we are grateful for that. So recognition for the need is most important. Second, you require government policy and priority for a neonatal care, which is still not in sight. As an IAP and as an NF, we are planning to do the neonatal care guidelines. So that is important. You require establishment of neonatal palliative care foundation. Like you have, now CIPLA Foundation, which is helping us along with Tata Memorial Hospital for our palliative care project. So you require a neonatal palliative care foundation. You require integration when existing healthcare infrastructure. I can't say that, let me have a separate ward and separate this thing. So you start with whatever healthcare infrastructure you have, you integrate in that, and depending on this thing, you can actually increase the, the palliative care, whatever you are providing to the baby. So integrate. The public-private NGO partnership is important. So here it's done in KEM, but it is under, the palliative care medicine department of Tata Memorial Hospital, CIPLA Foundation, and the pain and palliative care, the foundation. Everyone working together, you are, moving towards neonatal palliative care. And as we have said, we require neonatal palliative care legislation And the most important is community awareness. Whenever there is community awareness, it will help this thing to increase the palliative care. The need will be felt by the government and this thing, and putting all this sort of the parts of the puzzle together, we will be moving towards the neonatal palliative care. So when we looked at neonatal palliative care at KEM, we had started it. We were trained almost about 7-8 years back in neonatal palliative care at Tata Memorial Hospital. This thing, but we indoor. This is, and subsequently we started. In fact, this the thesis was given to one of my DM student in 2017, as a part of his DM thesis. But the neonatal inpatient care we started in 2021. There is a separate room where 2 beds are allotted for neonatal palliative care. And this CIPLA Foundation and TMH has given us 1 nurse and 1 counselor who work only for a palliative care, and 1 social worker. You have a goal-directed approach. You do data collection. We have preparation for memorabilia, which is actually shown here for a boy and a girl. And we write a message, which is, very touchy message, which is for the parents, and in Marathi and Hindi. And that particular thing is written inside this card. And if the parents want, we also put a photograph of the child. If they don't want, then it is not given. There are parents who say that we don't want this card. There are parents who take the card, and so this is given to them. And this is what we have observed over last 1.5 to 2 years when we have started neonatal palliative care. And you do, as I've already said, that we do NPC audit. So when we look at the neonatal palliative care is the need of the day. The India needs a move for creating awareness even amongst healthcare workers. The first crucial step is to identify the eligibility for the palliative care. You form a team for the same. You have a planned, systematic approach, and early initiation of palliative care is beneficial in enhancing the quality of life for that baby. So, as Albert Einstein has said, that the only source of knowledge is experience. And as we provide palliative care, we will understand where are we going wrong, what do we want to strengthen further, and what modifications are required. And our experience will actually increase our knowledge, and we'll be able to impart better care in the course of time. And at the end, I would like to say what Mother Teresa has said, that you begin with small efforts and then add on to make a big difference. So it might not be able, you may not be able to provide entire scenario of palliative care on day 1. You can take a small aspect, whatever, talking to the parents or allowing this, or whatever you consider is most important for your unit, helping them for for a death certificate. See that the body is not kept in the unit unnecessarily for a longer time. So one can take all these things, will actually help the parent to reduce the stress. And all of us have seen that that even a 90-year-old your person in the family dies, the entire family is disturbed. And here a child for whom the mother was looking forward for all these 7, 8, 9 months, this baby is born with some abnormality, some problem, and the baby is no more. The parents are actually devastated. So to reduce their stress, you can take some small efforts, help them, guide them, be empathetic to them. So you can start with some small efforts and then add on to make a big difference. Thank you very much.
Thank you so much, Dr. Ruchi. And that was really very enlightening. Dr. Sushma and Dr. Ruchi, I will start with 2 questions that I have seen in the chat, but I will invite more participants who want to then ask questions, even to unmute themselves.
Can you stop sharing the slides?
Yeah, yes.
Ruchi.
So it is still seen. 1 minute.
So Dr. Payal asked Dr. Sushma, please share the protocol. So
yeah, would be happy to share. I will put it in the group of the participants of one of the protocols. There are various others. I would be happy, but I have shared actually the references in the email Vanilla has already shared. And I think even in WhatsApp she has shared. But I can do it again.
Wonderful. Thank you very
So
much.
many countries are making it, and basically they're almost the same, you know. Everybody's aim is to improve the quality of life, and it's not the quantity, you know. You're going to make the parents comfortable, and you're going to give a holistic care, you know, which will include all their emotions, the social, the spiritual aspect. You know, it's a whole encompasses the entire care that would be given. So basically, all of them, as I said, would lead to the same thing.
Thank you. Thank you very much. So
Welcome.
basically, for us pediatricians, neonatologists, it's very important to develop that ability to manage palliative care cases. And there is a very relevant question to Dr. Ruchi from Dr. Gopi Krishna that asks, can we implement neonatal palliative care guidelines in rural setup and without a team? And that would apply to most of our participants and most people in India. Without a dedicated palliative care team, can we still apply those neonatal palliative care guidelines, which are not really existent, but those principles? Dr. Ruchi.
Yeah. If I get the question right, I think what he's asking is that how do we apply it in the rural area?
That's right.
Yeah, I don't know why are we very specific about rural area. We have to implement the palliative care, in wherever it is possible. And of course, the rural area comes in that. So first is, that's what we said, that first we have to have the guidelines. We have to have the healthcare workers which are trained. We have to know what is the basic focus of our guidelines, what we have. And suppose if you are doing in a particular, a rural area, if you don't have, team, you will always have a doctor, you are there. You will have a sister. You will probably have your junior doctor. So whatever facilities are available to you, you make a team. The team doesn't mean that you have to have a pain care specialist. You have to have a MSW, whatever best possible in your setup, you do that for the baby. Work for to relieve the baby's pain. You work for the end of life care, whatever, depending upon what the case is, and you deliver the care. And soon, I think the guidelines on neonatal palliative care will be available. Whatever we have our own guidelines. This is so that in that way we have to take it forward. So whichever setup you are in, whether it's a tertiary care NICU or it's a primary health, the first referral unit, whatever, or you have a rural area, the basic components will remain the same. You modify as per whatever the facilities available to you. The concept is more important.
And Dr. Ruchi,
it's very essential that we start even from rural areas, no matter, just like what Ruchi, I'm just reiterating a emphatic yes. The moment you think that you can run it along with, like Ruchi said, with your residents, with the gynac people, you may have a person who does the ultrasound. 3 or 4 is good enough, even a local leader from there, even a priest or a clergy, everybody can form the team who well understands and is in favor of it.
I think at least the 2 basic people will be available, that you yourself and a nurse. Now, you won't be managing a unit without a nurse. So at least 2 people will be there. You will have to probably, do more jobs. But the whole idea is to understand and do whatever best in a given setup.
In our setup, the most important person, I think, most commonly called to the NICU is the psychologist or counselor, actually. Yeah. But a nurse can develop those counseling skills. So actually, there are 2 questions that are very related, which is there a need to formally form a neonatal palliative care team? And does the neonatal palliative care team officially need to be identified by the director of the institute?
See, this is, again, it depends on where you are, what is your place of work. Now, if you ask me, this is that what are we doing at KM? That, as you know, ours is a public hospital. with the very busy NICU, whatever. But when we started this initiative, of course, we did take the permission from the commissioner, which is the means additional municipal commissioner, that we are going ahead with this. They had sent the document to the legal cell of MCGM, the Tata, and we had a memorandum of understanding between Tata Hospital and KM Hospital. It went through the legal, so the documents, we documented it on a proper stamp paper, everything, signed it, and then it was initiated. So in public hospital or in any setup, it's not that you can just get up and start a particular program. So you have to go through whatever rules and regulations exist. So depending on that, if it is required, the permission has to be taken.
Yeah.
I hope that is made it clear. Or
Yes.
yeah. So of course,
Yeah.
it means in a medical college, you will inform the dean. Here we have to inform the dean. We have to inform the director of corporation. We have to inform the additional municipal commissioner. And depending after the permission, you start any particular activity. It's not only for a palliative care. It might be starting a human milk bank. So you require, the permissions for a particular thing, and that requires to be followed up.
And then there is a very specific question. If you have a medical legal case, can we allow parents to take pictures of the child that has died? Like talking about memory making.
No, I think the way it was addressed wasn't this way. They said, is it medico-legally right to take? Ma'am, can we allow parents to take pictures of, medico-legal case? I'm not sure. I don't think
When the
so.
child is declared dead.
Sorry. No. See, that's what medical legally, see, we don't have the guidelines, on as far as the medical legal aspect of the palliative care is concerned. But if you have, sort of spoken to the parents earlier, you have counseled them, you have documented, whatever you have told them, you have documented that. Done all this particular thing, and then you are allowing the parents to take the pictures. It's not necessarily that you are taking the picture after death. As the baby is this thing, the pictures means we are allowing them to take the pictures of the baby.
So, Dr. Debetta, can you tell which was this medical legal case, like just for our understanding? Can you please unmute and tell us?
Dr. Debetta Shrikant?
Yeah. I hope whatever Ruchi has just answered, you have got the point of it. But if you want to give an example, please do unmute and tell us. Yes, Debetta, you're still there in the group. I can see.
But you are not, you are muted.
Yeah, please unmute.
Yes.
Ma'am, regarding any unknown poisonings, can we the parents ask us to take a pictures of that? Like we have declared, we are going to declare the death of the child. So if they want that to be taken as a picture, can we allow that one?
No, sorry, please be loud. We can't hear you.
Regarding any unknown poisonings, ma'am. Unknown poisonings where we
Unknown
ask
poisonings,
the
okay.
parents unknown, yeah.
But what's the goal of the picture? Because I think we are more talking about an infant or something like that.
Yeah,
So
no,
we are
unknown poisonings and all. I think in medical legal cases, if it's a definite medical legal case, I don't think we can take photos, like the parents can't take. You will need the police permission to take the photo then. If it's a medical legal case, like poisonings and all, I don't think so.
And when we are talking about memory making and offering taking photos of a baby, it's because that neonate has probably never, has not been able to go
those are
home.
not, Veronique, sorry to disturb, but those are not medical legal cases.
Yes,
Palliative
absolutely.
care. Yeah. So this he specifically asked for a medical legal case, which has nothing to do with palliative care. So I think that is a totally different topic, Debetta, and to whatever knowledge that I have, I think you need the police permission then to take photos. The very fact that it is an MLC and there is a poisoning, definitely, you need to take the permission. The police permission has to be taken.
Yes. And the last question, which is, from Dr. Sangeeta about dilemma in decision making in trisomy 18 or any condition that would be actually not compatible with life in newborn care units. It's probably no dilemma, I suppose. It's this baby would benefit from palliative care and non-intensive neonatal care. No, trisomy 13, trisomy 18. Am I right, Dr. Ruchi, Dr. Sushma?
Yeah, no, sorry, didn't get the question. Do we need any?
I'm not sure. The question, Sangeeta, would you like to say? Dilemma in decision making in trisomy 18.
See, we go by the parents. Of course, we tell them definitely what the outcome is going to be. They can't say now do each and everything, but to an extent, because trisomy 13 and 18 can live up to a couple of months also. So we try and take a midway. We do listen to them, and what will be medically and ethically right, that much treatment we would definitely give. It has to be a shared decision, explaining to them exactly what it is,
Great.
and how beneficial it is going to. They can't tell us now we'll undergo the, the complex heart surgery and all. So we need to explain to them that, the ultimate outcome is this.
So I think we have to wind up. Thank you very much to our two eminent speakers, Dr. Sushma Malik and Dr. Ruchi Nanavati.
Thank you very much.
And
Thank you.
so you will receive the post test by email. Please answer the questions of the post test that is necessary for your attendance. And looking forward to meeting you next week for the next session. Vinila, could you just tell us what is the next session about? I haven't checked it.
Yeah, so it's on
Thank
September
you.
30th, and the session will be on caring at end of life care for pediatric children, for pediatric patients, and it will be by Dr. Gayatri and Dr. Kritika.
Wonderful.
Next Saturday.
Thank you, Vinila.
Yeah.
Thank you.
Thank you. Thank you, everyone.
Good evening to all.
Yeah. Thank you.
Bye,
Have a
everyone.
nice weekend. Bye.
Thank you, everyone. Thank you so much.
Thank you, everyone. Bye.